welcome back. It's still Business Morning right here on Channels Television. Now, last week, there was an event, Access to Markets, and the whole thing was about Innovate Africa, and there was a whole lot of attention on the healthcare sector. We had innovators in that sector coming together, talking about breaking supply chain barriers, and some of those hurdles, on the African continent that has stopped us from maximizing it. And I had some interesting innovations there, which is why I thought we should follow up on that conversation. And we're having this conversation with the Director Operations at Sproxil, Ibrahim Alabi. Sproxil is one of the innovators at that event. Hi, Ibrahim. Good morning and welcome to the program.
Good morning. Thank you very much.
So, I heard you guys have some very innovative ideas that could help, especially people in the rural areas, because I had a lot of things about in native language, what can guide people and direct people in taking their drugs and medications.
Well, thank you very much, and nice to be here. So what Sproxil does is making those day-to-day healthcare activity, the basics, turning them to actionable intelligence on a national scale. I'm sorry, let me break that down. So if you've used you must have come across pharmaceutical products where you scratch the panel and confirm if it's genuine and all that, right? Now you would know that those products, as long as there's malaria somewhere, there'll be a malaria product. So Nigeria has a huge malaria burden, right? So there's basically malaria in every part of Nigeria. So which means the most rural part of Nigeria has some malaria products pack, right? And when that pack has a sticker, which is also most of it powered by Sproxil, we've been working with NAFDAC for about 15 years, where we have those stickers and you can confirm, text and confirm it's genuine and all that. Now, with that, when those packs go to those rural areas, every part of Nigeria, like as long as there's malaria, there's a pack of malaria, it means you can reach people depending on the kind of solution you are providing to them. So what those things do is that when people scratch and get and verify, right, genuine or not, we've gone a step higher, and over the last 15 years, we've had our scratch panel on about 4.5 billion products across different products and all that. Now, people are able to, we can now get intelligence from people to say, as soon as you scratch, you get another message. After you get product genuine, right, another message asking you some questions. For instance, you are taking the malaria product. Did you test before you did malaria? Because this information, this intelligence is very key for the elimination of malaria, because when people begin to take medicine without testing, you get to resistance and all that. We've gone past it with days of monotherapy, where products, we've moved to ACT now, where combination therapy, because there has been some resistance in past to the likes of chloroquine and all that. So when people scratch and get that message, say, give us some information. Did you test? Right? How much did you buy this product? Right? Did you get it from, did you go to a government hospital? Or you went to PPM, which are the local, what you call your typical chemists, the patent medicine vendors. So by getting this intelligence, right, we are able to support, and we have partnership with, formalized partnership with government agencies. NAFDAC is already there 15 years, the anti-counterfeiting. Now, during the I3, there was a MOU we signed, the National Malaria
with the elimination program.
The whole idea is provide this intelligence, actionable intelligence, on a national scale, and we are basically partnering. There's been intelligence before. What we are doing is improving on that real time. So in the past, or usually when you're trying to get surveys or get data of malaria, boots on the ground, people go around, training for several weeks and months, you go down, then you gather the data, you analyze, and those things are done every 3, 4, 5 years. So you might be doing some program on malaria today, but it's based on data from 3 years. But what we're saying is that those data, you can keep refreshing them actually on a daily basis. So same questions, did you test for malaria? How are you sure you have malaria? And many questions, a whole lot of questions. And those intelligence come in real time, and we can now disseminate and share with partners, right? So that is a part of it, ability to provide real-time actionable intelligence on a national scale, right? Also, in that process, health-seeking behavior, the part of what the NMEP, the National Malaria Education Program, is trying to achieve is people testing. I mentioned that before treating, which means what you call the rapid diagnostic test kits, right? So when you go to a pharmacy or a PPMB, your local patent, right, there's always an act that happens beyond the big pharmacies, the local guys, and they're regulated. They are not illegal. Government regulates them. So when you go to those areas, you have the test kits, and you test for, do you have malaria? No. And you can go beyond malaria, but malaria is this particular focus of that MOU. When you test, the PPMV, which is let me call it the chemist, your local chemist or pharmacist, if we put some 2D barcodes on those kits, your small kits, a 2D barcode, what happens is when you get the test results, or when you do that test, you take a picture of it, via WhatsApp, send it to a particular phone number. We have an AI system that will read that test result and tell you if it's positive or negative. Now, what does that do? Firstly, it tells you there's no mistake in terms of is it positive or negative. That's part one. But the part two of it is that you can build a national map of test positivity rates. So everywhere, every town, because it's geolocated, when you send it, you are going to get your geolocation. So assuming, for instance, today, 1,000 people use that kit across Nigeria, right? You are able to get the test positivity rates of malaria, and of course, again, you can be going beyond malaria. Real time in Nigeria, because it goes live into a live dashboard, is analyzed, and you can see real time how many people went there to report malaria, how many people got tested, how many people actually got positive on malaria. Because if you look at Lagos State data, for instance, Lagos State government is saying, in reality, based on the program they are doing in their government hospitals, about 3 to 5% of people that complained of malaria, that say, I have fever, I'm going to take malaria product. When they test them, as far as Lagos is based on reports from Lagos, just about 5%.
What about from your data using this system?
Yeah, so we've done different states, right? We've done Kano, we've done all that. It varies across the states. Lagos, of course, seems to be in the best position. Somewhere higher, when you go high up, the prevalence rate is higher. Some are 15%, some states have 25%. It varies across states. But what our system uses is that instead of waiting for years or months to get this data, you can do intervention programs today.
Exactly. So because that's what I wanted to ask.
Yes.
I'm glad that you have an MOU with the Malaria Elimination Program,
yes,
which is the government. So if, someone was sharing experience of how during COVID, when they needed government intervention, they just had an arm that had data. And then you know where to. So all this wonderful, he's not getting to who he's supposed to get to. So if the government is really serious, obviously, about dealing with an issue, because if we say what causes malaria, then we look at, of course, the environmental and the
those questions are asked too, right?
Exactly. So the data directs the government intervention and policy. That is, if the government would really want to use it. I wonder how much closeness you have, with the government, because this is an important data that paints the picture of the reality at least in the health sector for Nigeria.
Yes, I can say for free, right? The current administration, the current health minister, Dr. Alepati, with NMEP working closely. I include PVAC, the president team in charge of the value chain in the health industry. Right? There's so much interest in using this data, right? The stats, when we've worked with them, you can see the energy, again, coming from the minister himself, and we know who he is. His record is there to speak for itself. They really do want that data, which is what crystallized into signing up that MOU. Because ultimately, like he says, you are not going to solve this problem without having actionable and real-time data. And that is key. It's not that there's data and we can't run away from it. The NMP is very good in collecting data. But however, what we are doing is improving what is on ground and reducing those blind spots, right? Because the kind of data we get, you can actually filter down to the town and states. So let's assume, that there's things called malaria vaccines now. If you put the malaria vaccine intervention there, you want to know who got it, from where. Part of this solution, which is when it comes to even traceability, track and trace in supply chain, is saying if I send this to XYZ states, right, from warehouse A, did all the, let's say, 1 million units I sent, did it get there? Because by putting 2D barcodes on those packs, you scan at each level. So you know that when you're doing an intervention, if 1 million left here and only 500,000 was scanned, you realize that something got missing in between. So when government is doing intervention, government is looking at costs. So there are some programs government may want to do to say reduce the cost. But you know, if the cost is reduced, it can find a way into the black market. So by that data, you can track and trace where each and every one of those things are going. At the level of the pharmacy, right, or the PPMV, you can get result on test positivity rates by using these RDTs, rapid diagnostic tests, right? And at the level of the consumer, firstly, consumer can also, and say our technology can also verify if it's genuine, and even government could ask questions further to say, this product you buy, how much did you buy it? This is now information directly from the user. How much did you buy it? Where did you buy it from? Right? And all that. So this level of intelligence is there, and government, I can tell you for free, are very much willing in using it, which again can culminate into us signing that MOU.
And is it too early for us to expect an African outlook of all of this? Should we just deal with our home problem first?
No, it's all interrelated, right? Only that there are different regulations for different countries, right? But the solution itself is a pan-African, work anywhere. And the thing about it is that it's a localized solution, is by Nigerians. So sometimes there are solutions to bring in, but some of the things that I do is not localized for what you require in the Nigerian and even African context, right? But definitely that solution, again, putting 2D barcodes on RDTs, is just for you to snap and send to a phone number, and we interpret, and you can do this map across Africa. So we are a bit already in Kenya with some of our solutions. We're already looking at moving across Africa. But knowing that Nigeria itself is about 1 in 4 cases of malaria is from Nigeria.
Yes.
About 1 in 3 deaths.
The headquarters of malaria.
So there's a huge problem to be solved in Nigeria. However, that solution ultimately is a Pan-African solution, which we are working on. And again, because of the regulation, it might be slower, but definitely slow and steady, we get across Africa.
The race. All right, thank you so much. And we surely hope that it might be slow, but it's steady and progressive. Thank you so much, Director of Operations at Sproxil, Ibrahim Alabi, for your time.
Thank you so much. It was nice being here.
Same here.